So, hello everyone, and thank you for joining us for another Digital Infoday session. My name is Rebecca, and I'm one of the myeloma information specialists here at Myeloma UK. So if you call the Myeloma Info line, you'll speak with either myself or my lovely colleagues, Hayley and Ellen. We also respond to your questions through our Ask the Nurse service. Before we begin our event this evening, I'd like to go over some housekeeping. I'd like to let everyone know that this session is being recorded and will be available to watch on our Facebook page and our website soon after. We will be popping website links, publications, and useful information into the chat box throughout the event. If you have any questions that you would like to ask our expert, please use the Q&A box at the bottom or the top of the screen, and we'll try to answer as many as we can throughout the course of the event. Some of you may not be that familiar with what our organisation, so I'd like to tell you briefly who we are and what we do. Myeloma UK exists to support all of those affected by myeloma and its related conditions, which include smouldering myeloma, MGUS and AL amyloidosis. We are patient-focused and we aim to empower, inform and support patients in everything we do. As an organisation, we rely on the generosity and kindness of supporters who fundraise and donate. Myeloma UK is a charity solely funded by our supporters. We receive no funding at all from the NHS or government. Everything we do is funded by voluntary contributions, fundraising, and gifts left in wills. We are truly thankful for all your contributions as they allow us to continue working to help patients, their families, and their friends to put on events just like this one. Tonight's digital event is on understanding test results in myeloma. In this session, we will talk about what tests are for and how they are undertaken. Our speaker will also talk more about why you have particular tests and explain how to understand your results. So let's get started. I'd like to welcome this evening's expert, Dr. Fenella Willis. Dr. Willis has been a consultant haematologist at St. George's Hospital and has had an honorary senior lecturer post in the medical school there since 2004. She's also the clinical lead for the myeloma and apheresis services at St. George's Hospital and joined the Myeloma UK Board of Directors in 2020. So welcome, Fenella. It's really nice to have you back presenting for us, and I'll now hand over to you to start your presentation.
Thank you, Rebecca, and thank you everyone for joining us this afternoon. So hopefully we're going to take you through understanding test results in myeloma. And as already said, I'm Fenella Willis, so it's my privilege to be able to talk to you about this. So what are we going to cover? Well, how myeloma impacts blood, kidneys and bones. We want an understanding of your paraprotein, light chain, blood and urine tests. Tests that we use to investigate kidney function, and imaging tests for bones and the rest of the body. Hopefully at the end of this talk, there'll be 3 clear take-home messages. One is that myeloma affects multiple places within the body. The second is that a range of different tests are required to be done to diagnose myeloma and also to monitor the course of the disease. One test does not fit all. And thirdly, waiting for test results, we realise is a very anxious time. So it's really important that you're able to talk to members of your medical team or nursing team or a close friend or partner. So how does myeloma affect many parts of the body? So we need to understand really its effects on multiple things, including the blood cells, the kidneys, the bones, and the immune system. And to do that, we have to understand the tests that are done to look at these abnormalities. So we need to do a range of different tests to look at the process in diagnosing myeloma and to monitor the course of the disease. Any patient diagnosed with myeloma will undergo a series of blood tests. They will have X-rays and scans. They will have urine tests, and they will have bone marrow tests. And we'll go on to explain why all of these are important. There are a number of commonly asked questions. So what do the numbers in my blood count tests result mean? What should my free light chain test result be before I can start treatment? And how do I stop feeling anxious and stressed when I'm waiting for test results? So let's start with what myeloma is. Myeloma is a blood cancer, is a cancer of a particular cell called a plasma cell. And the normal site for a plasma cell in terms of where it lives within the body is within the bone marrow. Its normal function in the body is to produce antibodies, and those antibodies are important in fighting infections. They're also important in reacting to vaccinations, and they are a key cell within our immune system. When a plasma cell becomes cancerous or becomes myeloma, it still produces a protein, but that protein doesn't function normally and is known as a paraprotein. And that is one of the things that we will look for when we're trying to diagnose a patient with myeloma. This paraprotein, as I said, is a useless antibody. So it has the same structure or similar structure to what would be normal antibodies, but it doesn't actually have a proper function. It is produced by the cancerous plasma cells or myeloma cells. Each paraprotein will vary. It can be, or it is always made up of heavy chains and light chains. But in different individuals with myeloma, the heavy chains may be different. So if you discuss your myeloma with any other patients, you might find that they have a myeloma that has a signature of an IgG, and you might have an IgA. And that's to do with the heavy chains in your particular paraprotein that has been picked up. Because it's a clonal disease, which means all the cells are the same, when we pick up a paraprotein in a patient, they will have a particular signature to their disease. And so if they have an IgG, it may be that they've got an IgG kappa, and it will remain IgG kappa throughout the course of their disease, rather than swapping from kappa to lambda. And we call this light chain restriction. It means you can only have one type of light chain in your disease. We measure paraproteins through regular blood tests. So not only are they done at diagnosis, but they will be measured throughout the course of treatment and follow-up to use this as a surrogate marker really for what is happening within the bone marrow, because usually the level of paraprotein is directly proportional to the amount of myeloma in the bone marrow. So when you're looking at a paraprotein blood test result, if you're looking at what is the normal range, in a normal person, there should be no paraprotein. Only when there is a clone of abnormal plasma cells or myeloma cells will you detect a paraprotein, and it will be raised. We have to remember also paraproteins can be picked up in some of the precursor conditions, such as MGUS and smoldering myeloma. So these patients also have small clones of cells producing these abnormal proteins. Another blood test that might also see the result of is a total protein. A total protein is made up not only of the paraprotein, but also other proteins in the blood, such as albumin. Often at diagnosis, if you have a high paraprotein level, you may see that the total protein is raised. It is not always raised, so having a normal total protein level does not mean that everything is fine. It could be that you still have a paraprotein separately, but also that your albumin is low. Albumin is the other very important protein in the blood. So the normal range is between 35 and 50, and its production is often lowered as a result of active myeloma. So when a patient is diagnosed, we often find that their albumin is in fact low. Light chain results probably cause the most confusion when looking at blood results. In all people, there will be free kappa and free lambda light chain detectable in the blood. The normal ranges of kappa range between 3.3 and 19.4 milligrams per litre, and the normal range for lambda ranges between 5.71 and 26.3 milligrams per litre. We do know that the absolute values or normal ranges can be exceeded in other conditions other than myeloma. And this is very important. So in renal disease, so patients with kidney problems, this is separate from myeloma, they may have raised kappa and raised lambda light chains. We also see raised levels in patients with inflammation or infection. So when can we worry about it in terms of suspecting that this may be related to underlying myeloma? Well, in myeloma, we not only look at the absolute level of kappa or lambda light chain, but we also look at the ratio, and this is the kappa to lambda ratio, because usually in a patient with myeloma, this ratio would be abnormal. There is a normal ratio which ranges between 0.26 and 1.65. But usually in patients with myeloma, we know that actually the ratio will be either less than 0.1 or greater than 7. So a much higher ratio because of the abnormality, either in kappa or lambda. What's very important to remember is that in each individual, there will be a different result. It's not one result for all patients. So when we look at the level of paraprotein or the level of light chains, it is highly individual. And it's very important to look at that in context with all of the other results to be able to make a diagnosis. If we move on to the full blood count. So as I mentioned, myeloma affects or involves the bone marrow, and the bone marrow is the normal site for the production of normal blood cells. As the bone marrow gets filled up with myeloma cells, one of the direct effects of that is that there is a reduction in the amount of normal blood cells that are produced. And as a result of that, the different blood results which directly are lowered can be affected. So there are different types of cells within your blood that are lowered as a result of your myeloma. When we're looking at a full blood count, we can divide it into 3 areas. Firstly, the red blood cells. These contain the hemoglobin, and they're important for carrying oxygen around the body. So one of the effects we might see is a lowering of the red blood cell or anemia. Platelets are important in the clotting of blood. And if platelets are low, one of the effects we can see is risk of bleeding or bruising. And then there are white blood cells, which are important in the fight against infection. And there are different types of white blood cells. So sometimes, obviously, patients may be following their white blood cells, particularly if they're on treatment, because we're always anxious about the neutrophils, which are one of the components of the white blood cells, being either low or putting a patient at risk of infection. So when you look at your full blood count results, what might you see in terms of the normal range, and what happens in myeloma? So let's talk about the platelets first. The normal range is between 150 to 400 times 10 to the 9 per litre. And usually at diagnosis, this is either normal or can be lowered, as say, particularly if the burden of disease is high and the production of the normal cells is reduced. The hemoglobin is often affected in myeloma. And what is the normal hemoglobin? For men and women, it's slightly different. So for men, the normal hemoglobin range is 135 to 180. and women it's 115 to 160. This is often the first thing that gets lowered in myeloma. So in fact, if we look at patients when they're diagnosed with myeloma, and we were to look at their blood counts prior to their diagnosis, probably the first sign of an abnormality in the full blood count will be the hemoglobin. The white blood cell count, the normal range is between 4 and 11. Again, this may be lowered in a patient with newly diagnosed myeloma. And particularly the white blood cell count that we often comment on, which is the absolute neutrophil count, which ranges between 1.5 and 7.5 times 10 to the 9 per litre. This is often lowered in myeloma, but can also be lowered by the treatment that we use for myeloma. So what happens as a result of these blood tests being abnormal? When platelets are low, because of the risk, because of the effect on the clotting, there's a risk of bleeding or bruising more easily. When the hemoglobin is lowered, the main effect will be that of symptoms of anemia, particularly fatigue or potentially breathlessness. And when the white blood cell count is low, particularly the neutrophil count being low, there is an increased risk of infection. Apologies for that. So moving on to myeloma and the kidneys. So how does a myeloma affect the kidneys? So most importantly, we talked about the paraprotein and the light chains. And light chains are particularly toxic to the kidneys. Why are they toxic? Well, they are small enough to be filtered through the kidney glomeruli and into the kidney tubules. When they do this, normally what will happen is that they get reabsorbed and then filtered again, and they go through a cycle of going in of the blood and being filtered through the kidneys. But when the load is very high, they create these big proteins that become stuck in the tubules. And when they become stuck in the tubules, they crystallize and cause inflammation within the kidney, leading to kidney damage. And this is very relevant at diagnosis, particularly if a patient has any form of kidney disease at diagnosis, because one of the most important jobs that we need to do is to try and get the light chains down as quickly as possible to try and see whether we can preserve the kidney function. What blood tests do we do to look at kidney function? Well, the main blood test that we use is the creatinine. Creatinine is a waste product normally filtered by the kidneys, which is passed into the urine. And a high creatinine level indicates that the kidneys are not working normally. The level of creatinine is affected by a number of factors such as age, gender, ethnicity. So it's important that those are taken into account. And as a result of that, we often use what we call an estimated glomerular filtration rate to take those into account. So what is this estimated glomerular filtration rate? Well, it looks at the amount or milliliters of waste fluid that your kidneys are able to filter from the blood in a minute. So it's measured in mils per minute. And it's useful because it gives us a screenshot of looking at how well your kidneys are functioning. When the estimated glomerular filtration rate falls below 30 mils per minute, it's an indicator that we are heading towards severe kidney damage. And when it falls below 15 mils per minute, it is always concerning that actually the kidney function is getting towards a level where dialysis may be required. What other tests do we do for kidney function? What other tests include blood tests, as I say, for light chain levels and potassium levels. There may be other urine tests. We often, as well as looking at the serum-free light chain in the blood, we can look at the light chain in the urine, which is known as a Bence-Jones protein. We might also look at the amount of protein in the urine, because if the kidneys are not working properly, they might be leaking protein from the kidneys. And so we can look at the urine protein to creatinine ratio. And we also look for damage within the kidneys and blood in the urine. Occasionally, it might be important to do a kidney biopsy. Often when patients have kidney disease at diagnosis and a clear-cut diagnosis of myeloma, it's not necessary to do a kidney biopsy because we have enough evidence to demonstrate that that is the cause for the kidney disease. The time when a kidney biopsy might be useful is where it's not so clear-cut, and that can sometimes be in patients in some of the precursor conditions, such as monoclonal gammopathy of renal significance, where we see the kidneys are not working properly, and we think the paraprotein or light chain may be implicated in that kidney disease, but we can't 100% clarify that until we've got a kidney biopsy. So what are the symptoms of myeloma kidney disease? When the kidneys don't work so well, the symptoms patients might have include thirst, fatigue, nausea or vomiting. They can get headaches. They get shortness of breath, partly due to the fact they start to accumulate fluid, and they may get swelling of their ankles and face. They lose their appetite, and they might find that they're either passing excessive amounts of urine or very little or no urine. We move on now to myeloma bone disease. As we've mentioned, myeloma is a cancer affecting the bone marrow, which is within the bone. Bones are living tissues. They're made up of minerals, blood vessels, and cells. And myeloma cells can affect the normal maintenance of bone production and bone destruction. So our bones are constantly turning over and renewing themselves. And there is usually a balance between the cells that make bone and the cells that break down bone. Myeloma cells, unfortunately, increase the amount of cells that break down bone. And as a result of this, we get a net effect of more breakdown of bone rather than making of bone, which can cause holes in the bones, or what we call lytic lesions. So when we're doing screening imaging tests at the beginning of someone's diagnostic pathway, what we're particularly looking for is to see whether we can see evidence of damage to the bones as a result of myeloma. There are a number of different types of imaging. Most of the time these days, we tend to use what we call cross-sectional imaging. This is imaging where we can look at the whole body, and that might be either with a CT scan, or with an MRI scan, or with a PET scan. Skeletal surveys were done more historically. We tend to do cross-sectional imaging because it's more sensitive and it allows us to look in more details at the bone. The tests that are requested may vary according to the characteristics and symptoms of the patient you see. And the symptoms of myeloma. So, at diagnosis, you may get more than one test. So sometimes you might require both MRI scans and CT scans. And then during the course of follow-up, the imaging may be more directed to where the symptoms are occurring. So what are the signs and symptoms of bone disease? Well, as I mentioned, that we can see these lytic lesions, which are sort of classic sort of lesions seen in myeloma because of this imbalance between breaking down and making of bone. As a result of the myeloma, or potentially fractures, you can get pain and discomfort in the bones. And also, with extensive bone disease, there is often a leak of calcium from the bones into the blood, leading to a high blood calcium, which can be detected in the blood tests. We'll go on to additional tests, bone marrow tests. People often ask, well, why, if we've got all of these other tests, do we need to go on to a bone marrow test? The only way of histologically, i.e. getting the pathology for the disease, is by doing a bone marrow test, because this is the site where obviously the abnormal cancerous blood cells are found. When we do a bone marrow test, we typically do it from the pelvis bone. We can do a bone marrow test from other sites, but that's the most easy and the safest place to take a bone marrow. And as part of that test, there are two things that are done. The first bit is that we take a little bit of fluid from the bone marrow. This fluid is taken for a number of reasons. One is that we can use it to look at the blood cells and the myeloma cells under a microscope. And the other reason is that we can send it off to look for some of the very well-known signature chromosomal abnormalities that can be found in patients with myeloma. The second sample is a fragment of the bone itself. This is important because that can show the sort of histology of what's in the bone marrow, and can be used to obviously confirm the diagnosis. Patients often wonder what it looks like to look at a bone marrow. This is a sample of a bone marrow biopsy. On the left-hand side, it's just with an H&E stain. So you have the pinky strands, which are the bone, and the purpley sort of smeary areas with lots of holes in it is actually the bone marrow. And then on the right-hand side, we've used a particular stain called a CD138 stain to stain the plasma cells or myeloma cells. And you can see that the brown areas are where the myeloma cells are. In this particular patient, there's not a lot of myeloma, but there is a little cluster or a little lump of brown where you can see a little group of abnormal cells sticking together. So follow-up tests. So once we've got our diagnosis of myeloma and obviously are treating a patient, it's critical that we do follow-up tests on a regular basis. One of the reasons for doing those follow-up tests is obviously to look at how a patient is responding to treatment. The other reason for doing follow-up tests is also to look for potential toxicities of treatment that can be related to either the blood count, kidney function, or the liver function, because it's very important that we safely deliver the treatments. Most of the time, those follow-up blood tests, particularly in terms of the myeloma blood tests, are done around about a month on a monthly basis. There's no benefit really from doing it more frequently than that, and that's partly to do with the half-life of these proteins in the blood. If we do them too frequently, we're not going to see the difference in levels, either in terms of response or in terms of the levels rising. So usually once a month is absolutely adequate. During the sort of remission periods, we may not need to do it quite so frequently. And so the blood tests may be drawn out and done every 2 months or every 3 months, depending on the frequency of follow-up. I think Rebecca's joining me now.
Hello. Thank you so much, Vanilla, for your presentation there. That was really, really useful and really interesting. I really liked how you highlighted all the ranges in your presentation, but also how you linked that to the effect that might have on the body. And we always say to people on the myeloma info line that these two go hand in hand, that all the tests, regular tests that you have with your medical team are important, but it's also really important to be vigilant and just look out for any new or increasing symptoms that you may be experiencing, and just to speak with your medical team promptly about those as well. So yeah.
Yeah, and I think a lot of patients get access to their results immediately these days as well. So I think they're even more aware of blood test results, and are more curious as a result of what they mean.
Absolutely, yeah, we do get a lot of calls and a lot of emails about that, and I think your presentation will have been really, really helpful. So that's great, thank you. So we've now come to our question and answer section of today's event. So thank you for those who have submitted questions in advance. If you'd like to submit any more, then please do pop them in the Q&A box. We'll try our best to get through as many as possible. So let's begin. So our first question comes from Sue, and Sue asks, how high do light chains need to go before the next line of therapy is considered?
So that's a very good one, in a sense that when we're monitoring patients from their remission, and we're looking at what's happening in terms of the trend in terms of increase, there are some very clear guidance that we can have in terms of what constitutes what we call a biochemical progression, right? And if a patient has, they may have a paraprotein and they may have a light chain, and we might be monitoring both, or we will be monitoring both. And in some individuals, it might be that we're monitoring the paraprotein and we are looking for an increase of at least 5 grams per litre, okay, for that to hit the target for a biochemical progression. With a light chain, it's slightly more complex, as always. So we have to look at what is the abnormal light chain and compare it to the normal light chain. So for instance, if you are a patient that has a kappa light chain, you're comparing your kappa light chain to your lambda light chain. And you need an absolute increase of at least 100, okay? But we don't just look at one result. I mean, I think it's really important to say we're looking at a trend, and it's that trend. In addition to the light chain, we're looking at other trends of what's happening in terms of paraprotein, kidney function, blood count, because everything is relevant. But we do need at least a minimum of this change of 100 is usually the criteria. And that's very important because obviously clinical, if your next line of treatment may be going into a clinical trial, they will also be dependent on you achieving that before they would consider you for that clinical trial.
Thank you for that answer. That's brilliant. We do speak to people on the info line as well about how it's important that a trend is recognised as well, rather than a single test result. That's true, isn't it?
Absolutely. I think the trouble is that light chains in terms of advice do tend to be more variable than paraproteins. So we do sometimes see some patients particularly will have much more fluctuations in their light chain results. So we do always want to see a trend rather than just a single result.
Fantastic, thank you for that. So our next question comes from Stanislava, and they would like to know how low do hemoglobin levels need to go before a patient receives a blood transfusion. My dad's levels are low, 88 to 110, and he hasn't been given a transfusion yet.
So again, that again is a very individual thing. But if we take it sort of the average, most people will put a transfusion sort of target or threshold of about 80 grams per litre. So if it falls below that, it may be that they might consider thinking about giving someone a blood transfusion. But it's not an absolute figure, because if someone is clinically well and not getting symptoms and their hemoglobin is stable at 78, we wouldn't necessarily rush to giving a blood transfusion. So I think that's one thing to take into consideration. The other thing we have to always remember is when someone is newly diagnosed with myeloma, if they have a very high paraprotein, so I'm going to just give an example. So if someone was diagnosed with an IgG myeloma and their presenting paraprotein was 70 grams per litre, we might be a little bit careful about giving a blood transfusion if the hemoglobin is around the sort of mid 70s, because when a protein is that high, it causes the blood to be thicker than normal. And we call this hyperviscosity. So there's a risk of patients getting symptoms of hyperviscosity. So the target in terms of a transfusion threshold does depend on the clinical situation. It does also depend on other medical problems. So if, obviously this gentleman's father has significant heart disease, it might be one of the things that we decide that actually they need a slightly higher threshold in terms of transfusion threshold. So someone with very significant heart disease, you might say that you want to keep their hemoglobin above 85. So there is a bit of variation in terms of what that threshold might be.
That's great. That's fantastic. So it's a very individual thing, is what you're saying. Also, can we just touch on the hyperviscosity? What would be the symptoms of that? Is it something to do with the eyesight?
Yeah, so it can be, yes. So hyperviscosity, as I say, is something that sometimes when people first present with disease, or if they have a rapid relapse, could happen. Symptoms can vary. So it might be that they get visual disturbances, they could get headaches, they can get nosebleeds, they can get breathlessness. So they can be, or fatigue. So there can be a number of different symptoms associated with it. But as I say, it's always important to be asking those questions if you're worried about a patient potentially being at risk of hyperviscosity. So if we see a patient with a very high paraprotein, it's one of the things that we will potentially be looking for.
Great, thank you. So our next question is a very popular question, which quite a lot of people have asked actually, and it is, I always ask for paraprotein levels as a guide to how my myeloma is doing. Is this right, or should I be looking at other test results too?
Okay, so for most people, it's right. Okay, so there's always potential people that it might not be so helpful. But if you've got a disease which is producing a very clear paraprotein, and when you're having treatment, we'll be looking at the paraprotein as like a surrogate marker of response to treatment. So with each cycle, we'll be looking for that paraprotein hopefully to come down. And actually, in terms of the targets that we look for, we have what we call a partial response, which is where the paraprotein drops by 50%. We have a very good partial response where it drops by 90%. So yes, absolutely, we are tracking the paraprotein through the disease. The reason I say it doesn't always quite work that way with all patients is that obviously some patients might have a disease that only produces very little protein, which we call oligosecretory, or they might be a patient that produces no paraprotein, which we call non-secretory. And therefore, a paraprotein doesn't necessarily for all patients provide a useful tracking tool. So what's really important actually is for each individual is we look at what the best way of following up their myeloma might be. And decide on that, at the beginning when we are starting treatment. It might be that the light chains are the best way of tracking that patient's disease. It might be that the paraprotein is the best way. And it might be if they're non-secretory, we have to look at imaging as a way of tracking their disease.
That's fantastic. Thank you so much for that. So our next question, there's a few people asking online about the accuracy of bone marrow samples and other test samples. As it's taken from a very small sample, how reliable is that as a representative of the body?
Very good question. So absolutely, we are taking only a small area of the bone marrow, and myeloma can be a patchy disease. But we are doing it in combination with other tests, which is why it's quite important to remember we're using not only the bone marrow, but we're using imaging to look at the extent of disease. And we've got obviously the sort of paraprotein and the light chain. So we're looking at it as a combination of tests. The other bit that we're using the bone marrow for, particularly at diagnosis, is for taking tests to look for prognostic factors. So the genetic tests I briefly sort of touched on in terms of looking at what we call chromosomal abnormalities that can be associated with more harder to treat myeloma or high risk myeloma. So there are other reasons why we do the bone marrow tests as well.
Great, thank you for that. Our next question is from someone, Claire, and she says, I don't get any detail from my consultant at my consultations. I keep asking for figures, for example, paraprotein and light chains, so I can see a trend, but he won't tell me. Is this normal?
I wouldn't say that necessarily is normal. So most of the time, most people will discuss results, because obviously one of the important things is having that discussion, and it's a two-way discussion with your team. So you know, I think it's very reasonable to ask for a paraprotein result. You know, if the paraprotein results that the doctor's seeing you doesn't feel it's necessarily giving the full picture, or is the best test to be following up, they should be able to say that and explain why. But you know, if you're having treatment, ideally there should be some way of monitoring that you're responding to that treatment and getting some reassurance that that is the case.
Yeah, I agree. It's really important to have access to your results and have those explained fully to you. So next we have a comment from Stuart. Thanks to Stuart. It says many hospitals have patient portals allowing access to blood results, including paraproteins, as soon as they are available. This can help reduce anxiety. If you want to access your patient portal, speak to your CNS to ask whether this is possible. Top tip there.
Yeah. The other point of that, though, is that it can create quite a lot of anxiety, particularly around light chain results, because of the fact that I think light chain results are slightly harder to interpret. And so I know sometimes I've had patients come in very panicked about their light chain results, and I look at them and I say, oh, they look fine, actually, they're absolutely fine. So I think it's important, if you're anxious about those results, and obviously your clinic appointment isn't for another week. I know that's often what our CNS will be answering queries about. You know, the worst thing is to wait for a week, really anxious about the result. If you're really anxious about it, is I know our CNS is always happy to answer queries about that.
Yep, so it's always good to speak to your team.
Mm.
Great stuff. So next we have a COVID-related question. And they ask, how can having COVID affect your test results after recovery? Deborah would like to know if the COVID vaccine can increase light chains.
So yeah, that's a very good question. So as I mentioned in the talks, your light chains are not just indicators of myeloma. Your light chains will change in response to other inflammatory or infective symptoms in the body, or in relation to your kidney function. And so, yes, it is possible you can have a degree of change in your light chains after having a vaccination, depending on what the response has been. It wouldn't be a persistent abnormality. So this is the whole thing about looking at trends. And so if we were looking at the trend, we might see some fluctuations, but we wouldn't see a consistent rise.
Sure, that's perfect. Thank you for that. Our next question comes from Rachel, and Rachel says, how do I help my friends and family understand the uncertainty I'm coping with when I'm waiting for my monthly blood test results?
I think that's a very difficult question and very difficult one to cope with. I think the difficulty in waiting for results, the difficulty in going to a hospital appointment, is always around the anxiety of what's going to be discussed at that appointment and what's going to be discussed in terms of those results. Most importantly, the first step is to talk to those around you, your loved ones, family, friends, talk to the CNS and the medical team, particularly for finding that there's a huge amount of anxiety about waiting for these results, to try and work out ways in which that can be supported and managed, really. But I think we all appreciate the uncertainty every month. It is a very sort of anxiety-inducing moment waiting for those results to come back, because the response to treatment is so dependent on those results showing that response, and also, if the results don't show that response that you want, obviously that creates additional anxiety.
Yeah, for sure. We do have, just for information, we do have a really good pre-recorded digital information session on living with uncertainty, and it has Suravi Chaturvedi, who is a psychotherapist, and she gives all kinds of really great information and tips on living with that uncertainty. So that can be found on our Myeloma UK website. So our next question comes from Arlene, and Arlene would really like to understand how chemotherapy can affect the levels in the body and the ability to protect itself.
Okay, so I will say that we talk about the word chemotherapy, but actually our anti-myeloma treatments are a number of different therapies. So they are, some of them chemotherapies, some of them change the function of the immune system, or what we call immune modulatory. And then we have also antibody treatments. So all sorts of different ways in which we're targeting the myeloma cells. One of the sort of unfortunate sort of side effects of that is that it can also cause suppression of the immune system. And so when we look at the normal antibodies that would normally be sort of there, they're often very low in patients with myeloma. So we know that patients at diagnosis with myeloma, their immune system is often very suppressed. But equally, whilst they're on treatment, their immune system is often suppressed. And even when they're off treatment, it can take a very long time for their immune systems to sort of pick up again. It is one of the unfortunate side effects, not only of the underlying cancer, but also of the treatments that we use to treat that cancer.
Mm-hmm. Yeah, that's great. Thank you for that. So we do have time for hopefully another couple of questions. So we have one from Vicky, and Vicky says, when looking at PET or CT scans that have been requested for myeloma, can physicians look for other conditions too? And also linked to this, Derek has asked a live question, and he asks, is a PET or CT scan the gold standard in the detection of multiple myeloma in other unthought of areas of the body?
Okay, so if we start with the first one, is that if we're, for instance, doing what we call a low-dose CT scan to look for holes in the bones or lytic lesions within the bones, it's not unusual that we might pick up other abnormalities in the body. So it could be that we pick up abnormalities in the liver or in the kidneys or in the heart or the lungs. The scan itself is not the best scan to look at those other abnormalities in detail. Okay, so what will happen is quite often at a meeting when we're discussing the imaging, the radiologist will say, well, I've picked up that there is some abnormalities in the liver. It could be that these are just simple cysts, but actually to investigate it further, you need to do a designated scan of the liver. So yes, we do pick up what we call incidental other findings, but often we do need to do further tests to clarify exactly what those things are. And I think that's quite a common thing that happens, because we are looking at the whole body, and there may be sort of incidental things that we pick up as a result of that. Now, when we're looking at a PET CT scan, you have to remember we're using a particular tracer in this particular PET CT scan to look, which is very good at looking for myeloma. It's quite good for looking at for a number of other types of cancers. It may also be positive in situations of infection, but it's not necessarily the best tracer for all cancers. So it might not be the best tracer if we were looking for, I'll take a different example, like a neuroendocrine tumor. So there are different tracers that we use for different types of cancer that are particularly good for that particular cancer. So yes, we may pick up other abnormalities with the particular PET CT scan that we use in myeloma, but it may not be the best one if we were looking for a different type of cancer or a different problem. So the scanning department always need to know what you're looking for to choose the right tracer for your investigation. I can't remember if I answered both those questions.
Yeah, no, I think you did. That's brilliant. So different types of cancer are best looked for sometimes with different imaging techniques.
Yeah.
Great stuff. Perfect. And let's see, we've got a live question here from Jane. She says, I've now completed all of my childhood vaccines and my paraprotein and light chains have since increased from 0. Could this be anything to do with the vaccines?
Okay, so it all depends a little bit on the timing and what's happening and things. So obviously I don't know a particular situation. I'm going to take an example. So after someone has a bone marrow transplant, in the first few months after a bone marrow transplant, we can sometimes see sort of transient sort of small paraproteins, which are unrelated to the myeloma cancer. Okay, it's a bit of what we call immune reconstitution. Okay, the bone marrows and immune system starting to kickstart itself again and starting to get going again, and it can often cause a bit of anxiety. You see these sort of reports where it sort of will say something like zoning or oligosecretory bands, or there can be some slightly odd reports that come out as a result of that. And that's just, as I say, a kick-starting of the immune system. Now, after vaccinations, I don't think the vaccinations would necessarily have triggered the myeloma to recur. Obviously, depending on the timing after previous treatment, we know that myeloma is a disease that can sort of come back, and if it looks like it's exactly the same protein that was present before, that would be one of the things, obviously, that they would be tracking, whether it looks like it's a similar protein or something completely different. And it will again be the importance of looking at the trend, whether it was something that is trending upwards or, just a single abnormal result. So I think all of those things would be important to look at to make a decision about whether this was something that was clinically significant or not.
Mm-hmm. That's great. Thank you for that. So we do have time for one more question. So we get a lot of questions on the info line about if myeloma is an inherited cancer and if there is presently a screening test for family members of myeloma patients. Are you able to explain a little bit more about that, please?
Okay. So we don't say that, obviously it's not like a congenital condition in which you, from birth, inherit this condition, myeloma. Okay, but we do know that there are familial links or tendencies. So if you look at families, if you have a first-degree relative with myeloma, you probably have a slightly higher risk of being picked up as having the precursor condition MGUS. So we do know that there are some familial links, and it's relevant because obviously one of the things that's being looked at internationally at the moment is obviously, if we were looking at screening for myeloma or screening for MGUS, do you look at the whole population? Do you look at targeted parts of the population? And if you were looking at targeted groups within the population, which targeted groups might you look at? And so you would definitely think about obviously which groups might have a slightly higher risk of being able to pick up these precursor conditions such as MGUS. And MGUS doesn't mean you're always going to go on to get myeloma, but it just means that obviously we can pick up these paraproteins. But at that time, there's no signs to suggest that there's myeloma. And I think if we were doing a targeted program, one of the things that would be to look at people with first-degree relatives who have got myeloma as potentially being someone that might be useful to put in a screening program, but we're not quite at that point at the moment. But to go back to things, so you're not inherited, but there might be a familial higher risk of some of these other precursor conditions.
Yep, that's great. So the screening might be something that we have down the line in the future somewhere, but not at the moment.
Absolutely.
Fantastic. Thank you very much. So that's all the time we have now for questions today. Thank you for answering those, Vanilla. And I'll now pass back to you to continue with the last few slides and round up what we've covered in this evening.
Okay, so hopefully we've answered all your questions. So just a few more slides. So talking about waiting for test results. We've obviously mentioned already that obviously waiting for test results can be a very stressful and anxious time. And also the time that it takes for those test results to come through can vary. So particularly some of the test results around prognosis and the bone marrow samples take a lot longer than some of the other test results that come through. So it's important that obviously if you're very anxious about those results, that you're able to speak to your family, speak to your sort of friends, but also that you can talk to this through with parts of the medical team and nursing team. Myeloma UK actually have a patient diary, and this is really helpful because it can be used to keep track of appointments for tests, keep a record of your blood results. It has all of the normal ranges for test results within it. And it can be used to keep a list of questions that you might want to ask your healthcare team. And I think it's really important, when you go to your sort of consultation, it can be slightly overwhelming. Time can be a bit limited. And it can be very easy to forget exactly what you want to say to your doctor or your nurse. So I always recommend to patients, just write it down beforehand. And it's almost like a shopping list. We go through the shopping list and make sure that all of the things that you really want to ask are covered. Because then you'll go out of the consultation knowing that you've asked everything you wanted to ask and you haven't missed something. So, your patient diary or a record of what you want to ask is really important. So hopefully today this talk has covered obviously the impact of myeloma on the blood, kidneys and bones. It's helped you to understand some of your test results, particularly your paraprotein, free light chain, blood and urine tests, some of the tests that we use to investigate kidney function, and the imaging tests that we use for bones and the rest of the body. And we come back to our 3 take-home messages. See, myeloma affects multiple places within the body. As a result of that, we need a wide range of different tests to be done as part of either diagnosing myeloma or to monitor the course of the disease. And waiting for test results, we realise, can be a very anxious time. So it may help to talk with a member of your medical team or with a close friend or partner.
Thank you so much, Vanilla. That was brilliant advice. I really liked what you said then about the shopping list. That's something that we discuss with people a lot on the info line, just to make a list and get everything written down so that you don't forget anything, because clinic appointments can be short, you know, and you want to get everything in, don't you? So that was brilliant. Thank you. So I'd just like to mention some specific publications that you may find help from tonight's presentation. We have several treatment guides on our website, but the specific publications to mention from tonight's session are the Tests and Investigations in Myeloma Info Guide, Myeloma Bone Disease Info Guide, and the Myeloma and the Kidney Info Guide. We're here to support you, and we offer so many services where you can speak to someone who understands. We have our Myeloma Info Line and Ask the Nurse email service. Our information specialists, such as myself, are available Monday to Friday, 9 a.m. till 5 p.m. As well as all the info packs and info sheets mentioned in the chat, we also have a range of publications that you can download from our website or order a selection of hard copies. All of our previous digital Infoday sessions are up on our website and our YouTube channel, where you can watch them all on demand. So please do keep an eye out on our social media and websites for announcements of new upcoming events. We have our Peer Buddy service, which provides the chance for patients and carers to tap into the knowledge and experience of others in a one-to-one setting and talk to someone who understands. We also have the Myeloma Discussion Forum, a place to get involved in conversations and ask questions of others living with myeloma or related conditions. And lastly, we have a range of support groups all over the UK where you can meet other patients, carers, and family members. Connect with others. Myeloma is a very individual cancer, but you don't have to go through it alone. There are lots of ways to connect with others who know what you're going through. There's a link that's been posted in the chat to direct you to our services. So we've come to the end of our event today. Our thanks go to Dr. Vanilla Willis for speaking to us this evening. We'd also like to thank everyone who has joined us tonight, and we hope you found it helpful and informative. Just a reminder that you can now rewatch this event on our Facebook page, and it will be available on our website soon. If we didn't answer your question tonight, or this event has prompted some new questions, please contact us. You can do this via our info line or Ask the Nurse email service. Our contact details are on the screen now, but they can also be found on our website. Thanks to our supporters, Myeloma UK can provide free digital events just like this one for patients and their families. However you choose to support us, your generosity will help us to change the lives of people living with myeloma and their families. There's a link being posted in the chat to direct you to ways you can donate. So once again, I'd like to thank you for joining us, and I hope you enjoy the rest of your evening. Good night.